First, can you tell the quick story of, and that picture was so defining of that desk with all that paperwork. I've never seen anybody present a picture like that in a talk in 30 years. Because when I was a young guy in this biz, people would tell me the same thing. It's really, really hard to do the right thing. And they would show me all the paperwork they'd fill out and all the writing. So can you tell me sort of the quick story of how were you able to take this thing that was developed, I think, at the University of Heidelberg, right? And then move it this quickly to get FDA approved at 2 institutions, which will now make it available throughout the United States this year. Can you tell that quick story of how you actually believe that you folks could actually get an FDA approval of a compound?
So first, I think you bringing up Heidelberg is critical. Like they should get a lot, maybe more credit for this than anyone else, because they actually made this compound and they didn't patent it, which is an important fact. So it wasn't owned by anyone or by a company. But even there, before that, that urea backbone was actually made, if I remember correctly, at Georgetown University, because they were going to try to make a drug that targeted this. And then it was developed further elsewhere in the United States. Then there was collaborations with Heidelberg. There was teams of people at multiple different institutions working with very similar compounds. Hopkins University was doing a lot of work on this as well. So just think, PSMA 1007 means that there's 1006 prior molecules that were developed. So there's huge groups and teams of people that, were making this happen. So why did UCSF and particularly myself think this could be done? So first, Mayo Clinic succeeded with choline. They got a drug approved. And so I was like, well, someone can do this. So, maybe we could do this. And so that got me thinking that this is something academia could do. We opened our first trial in 2015 with PSMA-11. And Heidelberg was incredibly sharing. They gave us or lent us dosimetry data and toxicity data that allowed us to open these studies, which was absolutely critical. There's the nice thing about academia is people collaborate. And there's a lot of collaboration that helped encourage and make this happen. In 2015, I was 2 years into being a faculty. I didn't really know what I was doing. I did most everything myself. I did all of my own regulatory work, pretty much all the paperwork, and that created a lot of issues. And so it took a lot of people to help, sort of right the ship, make things going, documenting things properly, fixing up our chemistry sections, getting, FDA inspections are different than just publishing a paper. And so getting the thousands of patients' data ready for the FDA to come in was an enormous amount of work amongst a lot of people.
And so that was your target, right? As you set up these studies, which these prospective studies that had, almost 1,000 patients. You were looking for those 2 indications, those high-risk patients before treatment, because we never really had something, correct me if I'm wrong, we never really had something like this available before you even decide to be treated, right? So these are these high-risk patients. And then the second indication you got was recurrence, for a suspected recurrence when your PSA is elevated after definitive treatment. So you got those 2 indications. Was that your target? That was your goal? Or were you looking for more, less? When you were putting this together?
No, I was happy we got both. I didn't think we would get the initial staging indication at first. When we started off, the literature suggested our sensitivity for nodal nets would be something like 60 to 70%. And when we ran our trial, we ended up with a sensitivity of something like 40%, which was much lower than we had anticipated. And that was sort of obviously discouraging, but it's probably actually true. That's actually probably the true sensitivity. If you can have very small nodal nets at time of radical prostatectomy at surgery, 1, 2, 3 millimeter little nodes, and PSMA PET can miss those for sure. And if you look at the DCF-PYL trial that was just published, they also had a 40% sensitivity at initial staging in the same population. So I actually think that's the real number. Somewhere 40 to 50% is the sensitivity for nodal nets. So I was actually pleased that the FDA acknowledged, even though it's lower than we had planned, it's actually clinically relevant. And it's particularly relevant because it sees metastatic disease. And I don't think I really appreciated this at first. If you don't have pelvic nodes on a PSMA PET, then you probably don't have metastatic disease either. Okay, not probably. You really are unlikely to have METs. If you have nodal METs in the pelvis, you very well may have disease outside of the pelvis or more disease than we see. So it's really helpful, I think, as for a negative predictive value of saying, hey, you have high-risk prostate cancer, but if you're negative, you don't have anything outside of pelvis. So maybe pelvic radiation, including the nodes, or radical prostatectomy followed by salvage or something like that would be a good option for you.
So you got the two that you wanted. I'm probably killing the story. I did a lot of research for this, but there was some story I thought I read back a while ago. There was something that sort of inspired you from a patient advocate who was working in the neuroendocrine area. Wasn't that you? That kind of struck me because this is a patient advocacy meeting, right? Can you relay that? That was very inspirational. It was, you got something from a patient advocate that sort of gave you that oomph. And you'll tell the story better than I do. I heard it third hand. So how did that go?
Well, so actually I got into prostate cancer through neuroendocrine tumors. So we started doing gallium-68 DOTATOC imaging in early 2014. And that is a radio tracer to image metastatic neuroendocrine tumor. And the reason why we could go into prostate cancer is we had the gallium generator, we had the synthesis module, we had sort of chemistry workflow set up, so we could just use the same resources to do prostate cancer. And there is a patient advocate in the neuroendocrine tumor world called Josh Mailman, who is just amazing and wonderful in many levels. And he's from Northern California, so he runs NorCal Carcinet, which is our local patient advocacy group. And I've had been talking with him about, well, can we get gallium-68 DOTATOC approved? And worked with him, and actually the University of Iowa is an institution who's also been really great collaborators on many different projects, who had been working with gallium DOTATOC. And actually through this whole process, it ended up that Iowa got gallium-68 DOTATOC FDA approved in 2019. And actually that was sort of that's where I learned how a lot of these pieces work together. And Josh is pushing, and the thought that academia can do this. It's just very unusual for academia to get a drug approved.
Yeah.
It's happened 3 times. Iowa with DOTATOC, C11 choline with Mayo Clinic, and then us in UCLA with gallium-68 PSMA. So just having been close and familiar and interacted with all that really was very helpful. And without the neuroendocrine tumor experience, I would never have thought that we could have done this.
That patient advocacy, boy, that comes through again.